our scientific chairperson of WBAP, Dr. Abhijit Datta. I hope our president, Dr. Shushmita Banerjee, will be joining us very shortly. And we would like to start the program in time. And this is one of the very good program of WBAP for the students. And the students, it is expected that they will follow this program. And as a secretary of WBAP, Dr. Abhijit Datta, I hope our president, Dr. Shushmita. Hello. The students will benefit from this program of PG Masterclass. Today's PG's Masterclass is by Professor Ashok Datta, who is the teacher today. And the topic is how do we approach a case of congenital heart disease? Before going to Dr. Abhijit Datta, may I request all the PG students to become member of WBAP Central IIP, and so that this learning session can become very easy for all of you. Thank you very much. Enjoy the class today. Over to Dr. Abhijit Datta, Chairperson, Scientific Chairperson, WBAP.
Thank you, Indranil. Thank you, Professor Datta, for organizing this very important and very interesting class of the PG, for not only for the PG student, I must say, because we have learned some aspects of pediatrics and general medicine long ago. We are not updated in every field. This will be a sort of updation. And in our practice, we often get cases, and how should we approach those cases? And this is very important. Time is most important factor, particularly in a case of congenital heart disease. Now we all should learn from this program and will be enriched. So we should proceed. Now over to Dr. Ashok Datta.
Thank you. Thank you, Dr. Abhijit. And thank you, Dr. Indranil, Secretary, WBAP. And I'm thankful to WBAP President also for allowing me for this discussion. I am also thankful to our students for their attending the classes. And today I will discuss one important topics. That is the congenital heart disease. The incidence of disease is 6 to 8 per thousand. And remember, a large bulk of patients they are delivered with the congenital heart disease, and we will have to know the approach and how to manage it early and when to refer, when for surgery, because you see the pediatric cardiologist or the cardiologists are not available in all the areas of the country, particularly remote areas. It is the duty of the pediatricians to early diagnose the congenital heart disease and take the necessary steps for better management of these cases. Now, with this brief introduction, and again, after thanking to our WBAP for this very good program for PG students, I'm starting my classes and sharing my screen also. So let us start. I think I am visible and audible. Is it true? Am I audible?
Yes, yes. সব ঠিক আছে, দেখাও যাচ্ছে এবং পরিষ্কার শোনাও যাচ্ছে স্যার।
Okay, okay. So here I am giving one case just for initiation. A 1.5 years old baby is admitted for suffering from recurrent cough and cold, and previously has been admitted 3 times before this, not gaining weight for last 3 months, and now under medications. What will be our approach for these patients? Whenever we see this type of patient who is presenting with the recurrent cough and cold, it is in our mind to think whether this recurrent cough is related to some problems related in the lungs or some problems related in the heart. These are the 2 areas where this may produce. But usually we forget about the heart. In major times, we give more concentration on the lungs. And it is true that in some lung diseases, recurrent cough and cold may be the presentations. For example, in cases of, say, recurrent bronchiolitis, because the child is 1.5 years old baby. Even the allergic respiratory diseases may present recurrent cough and cold. In foreign body present in the lung may present with recurrent cough and cold. And even the other congenital malformation like congenital lobar emphysema or the mild variety may present with the recurrent cough and cold. These are causes in the lung. Tuberculosis presenting in the various ways may be one of the important differential diagnosis also. And some rare diseases, like not rare but some undiagnosed or say to some extent less common disease like the cystic fibrosis and others may present with recurrent cough and cold. The case of bronchiectasis may also present like this. These are one side of the case of the recurrent cough and cold. In the other sides, the recurrent cough and cold may be due to some heart diseases. We are going to approach how is it possible that heart disease, congenital heart disease, are presenting with the recurrent cough and cold. So, in congenital heart disease, who are presenting the recurrent cough and cold, the most important disease is yes, you see, the ventricular septal defect, VSD. Now, ventricular septal defect, you see, here there is a defect in the interventricular septum, and the blood is flowing from the left ventricle to the right ventricle, and through this, blood is going to the pulmonary artery. What is happening here? The blood during contraction, during systole, due to defect in the ventricular septum, the blood is going from left ventricle to the pulmonary artery, giving congestion in the pulmonary area. Congestion in the pulmonary area, the blood is going to the pulmonary artery, there is congestion in the pulmonary area, pulmonary vascularity is high, and if the pulmonary congestion is high, there will be some manifestations. The child will try to get relief from the congestion. And how the child will get relief? By cough. Second important thing is that if there is pulmonary congestion is present, obviously there is chances of infection. So pneumonia is also common, more common in this type of defects where there is increased pulmonary circulation. Now, if this pulmonary congestion is persisting for the long time, there is flow of the blood up from the pulmonary arteries to the left atrium via the pulmonary vein, and you, my students, will know that left atrium will be dilated in this case, left atrium will get enlarged, then the blood will pass the left ventricle, and the left ventricle will also get enlarged, so there will be left ventricular hypertrophy. In a case of ventricular septal defect, what is happening here? This you should remember that the blood is coming from the left ventricle to right side and then immediately going to the pulmonary artery. So right ventricle is not taking the load of the blood at all. because right ventricle is acting as a conduit or passage of the blood from the left ventricle to the pulmonary vessels. So which ventricle is taking load in a case of ventricular septal defect? It is the left ventricle which is taking the load, and left ventricle will get enlarged, and this enlargement is due to increased amount of blood in the left ventricle. So left ventricle will get dilated, the left ventricle will be dilated, and there will be congestive, hypertrophy of the left ventricle. Apex of the left ventricle will get downwards and outwards. Left ventricle will try to pump the blood with the more force, because the more amount of blood is coming to the left ventricle. And you know that when the blood is coming more amount to the left ventricle, the ventricular muscles get stressed and it will contract with more force. When the more blood is returning by the pulmonary artery, pulmonary vein, left atrium to the left ventricle, the ventricular muscles fibers, they get stressed and it will get more force of contraction as per Starling law. But that is up to a certain limit. When the limit is crossed, the left ventricle will fail and the patient may present with the features of acute left ventricular failure. And in that case, the child will present to you with the severe respiratory difficulty, and there is a tachycardia, there is tachypnea, there is a profuse capitation throughout the lungs. The gallop breathing is there, but it's difficult to get the gallop breathing because of the capitations which is present, and liver is enlarged because of the congestion, though it may not be present always in acute left ventricular failure. So what is the most important presentation is the severe respiratory distress, and if you are very much expert, you can get the clinical findings of the ventricular septal defect like murmur, etc. It is difficult to get that. But one thing which is common, there is the left ventricle will enlarge because of the left ventricular congestion. And if you examine the heart, and I think you know how to examine the heart, and if you see the apex is downwards and outwards, you will think that this respiratory distress may be due to some cardiac origin, and subsequently you control the acute left ventricular failure by giving diuretics and a requisite amount of doses. And usually diuretics suffices. We present day avoid to use the digitalis in these cases. Digitalis is controversial in these cases. Some people suppose that you give the digoxin or diuretics together, and some people in favor of diuretics and the AC inhibitor like captopril, etc. But except diuretics, both of these drugs are controversial. We are using this captopril or enalapril in children. With this, you will see the different directions that in a case of left ventricular failure or congestive cardiac failure, these are given diuretics like furosemide and also the AC inhibitor like enalapril or captopril. But remember, till up to the age of 6 years, enalapril and captopril recommendation is not universal. But one important thing is that if you give this AC inhibitor, it will retain potassium. You need not to think about the hypokalemia, which is produced by the furosemide. But remember, the furosemide single use also rarely causes hypokalemia in the small child. So most important drug is diuretics. You should save, it can save the life of the child, and the dose may be say 1 to 5 milligram per kg in 3 divided doses depending on the severity of the cardiac failure. So see, this is one way of the severe respiratory distress presenting case is ventricular septal defect. Now, second important thing is that whenever the more amount of blood is going to the ventricular septum, the pulmonary artery will get the more and more amount of blood, and that will go to the lungs, and the continuous Here the difference of the pressure and volume both are much more in the pulmonary artery. You see, normally what is happening during contraction, the left ventricular mean pressure is about 100 milligram of mercury, where the pulmonary artery mean pressure is 25 milligram of mercury. So what is happening, there is large amount of pressure is transmitted along with the blood to the pulmonary artery. This large amount of pressure and the blood volume both together causes some changes in the pulmonary arteries. And what are those changes? If you do not treat this child for the long time, if they are present for the long time, what will happen? There will be hypertrophy of the tunica media, that's the middle muscular layer of the small vessels, and also there may be a hypertrophy of the tunica adventitia, that is outer fibrous tissues, or tunica interna, that is the internal lining of the endothelial lining. All they get hypertrophied, and as a result of which there will be narrowing of the arterial, there is narrowing of the pulmonary capillary, resulting in the more and more pressure in the pulmonary artery, and net result is pulmonary hypertension. Now, if there is pulmonary hypertension, if the hypertension is present in the pulmonary artery, then the blood is ejected to the pulmonary artery via the right ventricle. The right ventricle will have to work much more, because both the ventricle will have to work much more. So there will be biventricular hypertrophy along with the left ventricle. The right ventricle will get the hypertrophy. And remember that when the pulmonary circulation is reduced due to pulmonary hypertension, left ventricular size also get reduced. And the symptoms of respiratory difficulty, symptoms of recurrent pneumonia, symptoms of heart failure, that will also get reduced because of the development of the pulmonary hypertension. But this is not a good sign. In this case, we will have to sacrifice, child is to sacrifice. How? There is pulmonary hypertension, and this hypertension causes right ventricular hypertrophy. There will be some say diminution of the shunt, and diminution of the shunt because of the right ventricular hypertrophy and increased pressure at par with the left ventricle. So there is no shuntage here. But if the pulmonary hypertension is much more and more blood from the right ventricle may pass to the left ventricle, the reverse flow of the blood from right ventricle to left ventricle, giving rise to a complex known as Eisenmenger complex. And in that case, the child will present with the cyanosis and effort intolerance, that is respiratory difficulty while doing some work. So this is a dangerous state, and it is irreversible, and the child will die due to hypoxic cardiac failure. So this is a very important to remember. One of the important cause of the recurrent cough and cold in a small child. Usually this starts from 6 weeks of age, but sometimes if the ventricular septal defect is much larger, then it may start before the 6 weeks also. Now, why the 4 to 6 weeks age is considered for the passage of the blood from the left ventricle to the right ventricle? Because you see, when the child is born, now what is happening? There is some pulmonary vessels, lung vessels, they're very small. Pulmonary arteries are collapsed. So pulmonary vascular resistance are very high when the child is born. This pulmonary vascular resistance falls after say 4 to 6 weeks to adult level. And when the pulmonary vascular resistance is high, naturally the shunt is also low. So when the pulmonary vascular resistance falls, then the shunt will go high and the baby may present with cough and cold. This is the reason why this type of patient, where there is a left to right shunt, they usually present at 4 to 6 weeks of age. And they start with the cough and cold. And this cough and cold, the reason I have told you before, because of the pulmonary congestion, child wants to get relief. Sometimes this congestion invites infection, giving rise to recurrent pneumonia. Sometimes the left ventricle is overloaded and fail, and left ventricular failure. And sometimes the child, it may so happen, the child is having the congestive cardiac failure under, say, somehow it is controlled by some drugs or other measures, and there may become cases of compensated cardiac failure. That is, the cardiac failure is not fully controlled but partially present, but it is also not severe enough. And if you do not treat this patient adequately, the child may pass on to reversal of shunt and giving rise to Eisenmenger complex. There is also, let us go to the another disease, the atrial septal defect. Here the defect is at the, say, at the level of this. The atrial septal defect at the atrial septum. Remember, this atrial septal defect, when it occurs in the middle at the site of the foramen oval, so there may be some disease of, say, second type of defect. Sometimes this defect may be present at the lower part of the atrial septum, in the lower part, in these regions. This is called ostium primum type of defect. And this defect, this orifice may present just below the origin of the superior vena cava or just after inferior vena cava here. Now what is happening? This is called venosus, sinus venosus type of septal defect, or sometimes it may present in the near to coronary sinus. This is called coronary sinus related atrial septal defect. So there are different varieties of atrial septal defect. Now there are some differences of manifestations of ASD, atrial septal defect, and the ventricular septal defect, which I have discussed before. What is happening here? Now left atrium is, because of the higher pressure in the left atrium and right atrium pressure is low, the blood will pass from the left atrium to the right atrium. But here the pressure difference between the two is very small. If I consider the left ventricular pressure is near about, say, 20-25 millimeter of mercury, right atrial pressure is usually 0 to 5 millimeter of mercury. And if I see the difference, you see the left atrial blood will go to the right atrium, but it is more from the left, it is more the volume, not the pressure. Because the volume, more volume is going to the right atrium, it will pass to the right ventricle. Here the right ventricle will get taking the load, and right ventricle will be enlarged. And you know the right ventricle has the capacity to enlarge. It can incorporate the blood there. So, and it will eject the blood to the pulmonary artery. And what will happen? The pulmonary artery gets dilated, and it will take the, say, it will accommodate the blood there. Here is also left to right shunt, but manifestation may be delayed. If the left to right shunt, the atrial septal defect is, say, very large defect, and that is, say, sometimes it is called the large defect, means if it is more than 8 millimeter defect in the echocardiography result. If the large defect is there, it may manifest at the very early age, at the age of 1 year or at the age of 1.5 years. Just I give the example of that case. But if the defect is small, it may not present before the school age, that is before the age of 5 years. Usually it gets asymptomatic and it is detected routinely by routine examinations. Now, in routine examination, if you find the right ventricle is enlarged, the left pasternal heave is there, and if you find the second sound,
খালি যাদের লিখি তাদের, এই যে তোকে বলছি ঘাটা হয়ে যাও তারপর লিখবো।
if you found the second sound is usually splitted. Second sound is usually splitted here. There is wide and fixed second sound. There is wide and fixed second sound during this period. This wide second sound is due to more amount of blood is coming to the right ventricle, and it is taking more time for the pulmonary artery, for the clearance of the blood from the right atrial to ventricle to the pulmonary artery. So aortic closure is normal, but pulmonary closure is delayed, and you see the right atrium is always full of blood during inspiration. During inspiration, what is happening? because of the negative intrathoracic pressure, more and more blood is coming to the right atrium, and during inspiration, as the more and more blood is coming to right atrium gets extra amount of blood. During expiration, when not more amount of blood is coming here, the blood in the expiration is coming from the left atrium to the right atrium much more. So during inspiration and expiration, both time, the right atrium is always full of blood. During inspiration, because of the negative intrathoracic pressure, more amount of blood is coming to the right atrium. During expiration, the more amount of blood coming from the left atrium to the right atrium. So what is the net result? Right atrium is always full of blood, extra blood. This extra blood is going to the right ventricle, and that will eject through the pulmonary artery, and that will take the fixed time for the ejection of the pulmonary artery. So wide and fixed second order sound is found in atrial septal defect. In addition to this, you can get a murmur at the pulmonary artery site, ejection systolic murmur. I'm not discussing any clinical methods here, just I'm telling just key point for the diagnosis. In case of ventricular septal defect, what is happening? Here this blood will try to pass in VSD just after systole, just when the systole begins, and that is just after closure of this atrioventricular valve closure, which is producing the first sound. Just after that, the blood is passing. So faster sound, which is produced due to closure of this valve, just at the beginning of the systole, that will get muffled in the case of VSD. So faster sound is muffled here, and you will get a murmur because blood is passing through pulmonary artery, and that will extend from the faster sound to second order sound. This murmur of the VSD is called pansystolic murmur. Whereas in case of atrial septal defect, you see there is no problem with the atrioventricular valve. So there is no question of any faster sound abnormality. So faster sound will be normal here. Only what you see, the more amount of blood is going to the pulmonary artery, giving rise to a murmur, systolic murmur. So as the faster sound is normal, you are getting the systolic murmur, and there is no question of any relation to any valve here. This murmur is known as ejection systolic murmur. So in case of VSD, you are getting pansystolic murmur. It means the faster sound is muffled and the murmur extends from the faster sound to second order sound. In atrial septal defect, you will get some sort of ejection systolic murmur. The ejection is due to passing blood through the pulmonary artery. Faster sound is normal. Second order sound is also normal. You know the second order sound is due to closure of the semilunar valves, the aortic and pulmonary valves. And naturally, in case of atrial septal defect, the pulmonary valve closes late. I have discussed this before, so there is wide and fixed speed of the second sound. Very important clinical clue. Eisenmenger syndrome and cardiac failure may occur in atrial septal defect. Some of the students sometimes think that, sir, is it possible for ASD to develop the Eisenmenger syndrome or the cardiac failure? The answer is yes, it is possible. If the ASD is large enough, it can give rise to pulmonary hypertension. So remember, the large ASD should be taken care of early. I will discuss the consensus guidelines for the Indian content, what should be the ideal guideline in the after next few slides, after going to the initial discussions. Next important thing is the ductus arteriosus, that is patent ductus arteriosus, and you know this ductus arteriosus is connected just from the left, just at the beginning of the left pulmonary artery to the aorta, just juxtadistal to the left subclavian artery. This ductus arteriosus has tremendous role for the survival of the patients in some cases where there is ductus dependent circulation. Just this is not the discussion of today, but just for the PG, I like to mention this one. This ductus is sometimes may be very much helpful in cases of newborn. Suppose a newborn is delivered just with severe cyanosis. You don't know what is the origin of the cyanosis, but you have excluded the pulmonary origin. That is, you have excluded the Highland memory disease. you have excluded any respiratory distress syndrome, and but you will see that severe cyanosis is there, probably of cardiac origin. In that case, the doctors is very much vital, because there are some cases, suppose there is some say here, they say aortic atresia. In aortic atresia, what is there? What is this? The aortic valve is not produced, it is already narrowed, no blood is going to the aorta. What is happening there? Distal circulation is totally dependent on the ductus arteriosus. In case of pulmonary atresia here, pulmonary atresia, the blood, no blood is going to the pulmonary artery. How the lung will survive? Then the blood will come from this aorta to the pulmonary artery and supply the blood. This is the importance of ductus. Suppose there is a hypoplastic left heart is not properly developed. In that case, the right ventricle will supply the blood via the pulmonary artery to the aorta. Suppose there is a hypoplastic right ventricle. In that case, the left ventricle will supply the blood to the ductus. So ductus is very, very important in cases where it is required. So in case of critical pulmonary stenosis, in case of pulmonary atresia, in case of aortic atresia, hypoplastic left heart, hypoplastic right heart, etc. So in those cases, or in cases of sometimes say interrupted aortic arch, from here there is interruption is there, then ductus is the only site for circulation. So this is very important to remember. In the newborn cases, if you find any cases, any baby with the cyanotic heart disease, not due to lung origin, we will have to keep open this ductus arteriosus till echocardiography or till the advice of any cardiologist by giving poststanding E1 infusion. And PGE1 infusion is very, very important drug to keep patency of the ductus arteriosus. PGE1 infusion is available usually close to any larger health centers or say hospitals. And PGE1 infusion, if you give the baby, you can save the life of the baby. And in some cases, the ductus dependent circulation. In PDA, you get the two types of manifestation may be there. Sometimes the PDA may be unnoticed in the newborn period, and in the say older children you are getting PDA. So you should not keep the PDA unless it is very small. So PDA hemodynamics is similar to the left to right shunt with high pressure, like the BSD. Here what is happening in PDA, as soon as the blood is going to the aorta, immediately it is passing to the pulmonary artery, because there is huge pressure difference between the two. Mean aortic pressure is about 100 millimeter, mean pulmonary artery pressure is 25 millimeter. So there is 75 millimeter pressure difference. So blood will pass from the aorta to the pulmonary artery immediately, and there will be pulmonary congestion. If the pulmonary congestion is there, the baby will present with the recurrent cough and cold, and it will start from the 4 to 6 weeks of age, and it may present with the recurrent attack of infection, chest infection due to recurrent pneumonia because of the pulmonary congestion. And the same like ventricular septal defect, it may present with the acute left ventricular failure like the severe respiratory distress. And similarly, as the pulmonary artery is facing with the large amount of the say pressure in ductus arteriosus, so what will happen? The chances of Eisenmenger syndrome, here it is not complex. Eisenmenger complex, Dr. Eisenmenger first uttered the term Eisenmenger complex in case of BSD with reversal of shunt, or in other areas like the ASD or PDA with reversal of shunt, you should call it as Eisenmenger syndrome. So remember this, Eisenmenger is also common in the case of large PDA. You will have to manage this in the patient with the recurrent cough and cold. So this is the important thing. But difference between the PSD and PDA is that in PDA you see the blood, large amount of blood which is returning to the left ventricle because through the pulmonary artery which is getting through this ductus arteriosus. This large blood, when it passes, produces an impulse in the arterial wall. This impulse is going to feel as a sudden rise of the pulse wave, sudden rise of the pulse wave. And immediately after the sudden rise of the pulse wave, the blood is passing to the pulmonary artery. So sudden rise of the pulse wave and sudden fall of the pulse wave, it is known as collapsing type of pulse. This collapsing type of pulse you will get in case of patent ductus arteriosus. There are other conditions of collapsing of pulse you will get, like aortic regurgitation, how the blood is say going here and immediately coming back here, aortic regurgitation, or if there is a aortopulmonary fistula, or if there is any other areas where there is arteriovenous fistula, it may be at the coronary arteriovenous fistula, it may be at the systemic arteriovenous fistula, whatever it may be, when the blood is going to the artery and immediately passing to the veins in any regions, it can give rise to collapsing of the pulse. Very important sign. I think my PG students will know how to see the collapsing pulse. You just feel the pulse here, then raise the pulse above the cavity and feel it is more. That is called the collapsing pulse. So other important differentiation is that because the blood is passing from the aorta to the pulmonary artery, both in the systole and diastole, you will get a continuous murmur here, At the left second intercostal space, at the left infrascapular regions, you will get the continuous murmur. And this murmur is so much so sometimes it is called the machinery murmur. And what is happening is that you will get the faster sound, because faster sound is the closure of this semilunar atrioventricular valve. Faster sound is normal, but you cannot hear the second sound because the murmur is present. Murmur is present at that time, so it prevents you to hear this closure of the semilunar valve. So second sound is not clearly audible here. Second sound is not audible, faster sound is audible, and the murmur present in the systole and diastole, both continuous murmur is present. Murmur is continuous because second sound is not present. Murmur is present from systole to the almost early part of the or later part of the diastole also, depending on the size of the ductus arteriosus. So these are the three important conditions where you get the pulmonary congestion because of the more amount of blood going from the left to right side. There is another condition which is, this is not very common. This is known as endocardial cushion defect. It is more common in cases of Down syndrome. And if you see the 100 cases of endocardial cushion disease, you will see nearly 33% cases. So 33 cases are due to Down syndrome cases. What is happening there? It is in endocardial cushion defect. The defect may be at the ventricular septal defect, large ventricular septal defect, ostium primum type of defect. There will be defect in the tricuspid valve here. There will be mitral valve cleft or mitral regurgitation is there. So VSD, ASD, mitral cleft or regurgitation, tricuspid cleft or regurgitation, whole comprise the endocardial cushion defect. This endocardial cushion defect is complete endocardial cushion defect. Suppose the VSD is not present, suppose the mitral valve is not, say, totally affected, tricuspid valve is not affected, or mitral valve is not affected, only the ostium primum is present, as I have discussed before, then it is called the partial endocardial cushion defect. So if say ostium primum defect of ASD is present, it is partial in ECD. If all other things are associated with this, particularly VSD and the mitral valve and occasionally the tricuspid valve, it is called the complete endocardial cushion defect. Here the manifestations, the problem is that the child is present because the VSD is larger, all other signs will be masked by these VSD findings. So you will get the features of VSD, and that is pansystolic murmur. You see the faster sound is muffled because the valves are not able to close properly, and pansystolic murmur which is present both in MR, mitral regurgitation, or the VSD, that will be present there. And second sound due to closure of the semilunar valve which are not affected. So murmur will pass from the faster sound to second sound because of the VSD. So it will present just like cases of VSD, but you will have to investigate the cases to find out whether endocardial cushion defect present or not. And And you see in all Down syndrome cases, irrespective of any clinical findings, you will have to do the echocardiography, must. This is an important information you should remember. Two important things you should do all Down syndrome cases. One is thyroid screening, you must do because hypothyroidism is very common. And second important thing is the echocardiography to exclude endocardial cushion defect. Though other defect like the VSD or coarctation of the aorta may be present in association with Down syndrome, but endocardial cushion defect and other things should be excluded. And you see, what's the importance of this? The importance is that because the endocardial cushion defect is a very high chance of development of the pulmonary hypertension. The child may die because if you do not take adequate care, immediately child may die because of the development of the pulmonary hypertension. And here the important thing you see the right ventricular and left ventricular pressure, left atrium, right ventricular pressure, all are say equal. So you see all pressures are equal. See how much blood amount of pressure is developing in the pulmonary artery. So pulmonary hypertension is very common. You will have to exclude this, and you may present just like cases of ventricular septal defect. So all these cases are from the left to right shunt. I know there are lots of details are there to discuss about the left to right shunt, but as the time is limited, I am going to the second case, and this second case is there. Now case number 2. Now Putu late 2 years old baby suffering from bruised discoloration of skin and mucous membrane since 6 months of age. She was admitted in nearby hospital twice before. This time mother noticed that her baby's weight is declining and also the bruised discoloration is increasing. She is also giving history of frequent cry. How to proceed for management of Putu? So this is a very common case, and usually what we do from our previous learning, when we were student of say MBBS or just let's say DCA student or very early part of the MD, a 2-year-old child presenting with the bruised discoloration of the skin and mucous membrane, you jump on the diagnosis in the case of tetralogy of Fallot. But with the advent of the echocardiography, now we are getting large amount of cases which are presenting just like this of compromised circulatory status, and maybe due to different cases other than tetralogy of Fallot. Though till tetralogy of Fallot is the most common cyanotic heart disease in children, but we will have to think of other diseases also. Let us go to see the important cyanotic heart disease, because complex cyanotic heart disease are a large number of there, and sometimes it is very difficult to diagnose clinically about the complex cyanotic heart diseases, and you will have to assess that it may be there, and you should take the help of the echocardiography. So much so nowadays in major medical colleges, also in newborn care centers also, essentials, echocardiography machine is given there. There is also short training of echocardiography is there, and in the pediatrics wards also PICU there is echocardiography machine are there, so that the office echocardiography can be done by this, so that early suspicion is essential. Let us go to these cases. We are coming to this case later on. This is important case. That is you see here what is happening in this. Now, this is the case you see this is the ventricular septum. This is the lower part of the ventricular septum, and the upper part of the ventricular septum is here. Here there is upper part of the ventricular septum. It is shifted to the right. Ventricular septum is shifted to the right, and because of the shifting, or that is malalignment of the ventricular septum, there is a large orifice that is known as ventricular septal defect, and it is large orifice, so it is Non-restricted, there is no restriction is here. And you see because the shifting of the ventricular septum, the pulmonary artery is getting narrowed here. So there is pulmonary stenosis, and you see the huge diameter of the aorta here. Aortic diameter, you see the huge amount of diameter is there. Aorta is overriding. Aorta is origin from the left ventricle, and it is also overriding the same, almost same area with the right ventricle. So aorta is overriding the right ventricle. And as a result of this pulmonary stenosis, nature always try to pass the blood to the pulmonary valve, and as it is getting obstruction, so there will be right ventricular hypertrophy also there. So here, if you look at this case, you will see the basic defect here is the developmental defect of the heart. What is the developmental, what defect is present here? In this developmental defect, the ventricular septum is developing properly in the lower part, but the upper part or infundibular part of the ventricular septum is not properly developed. It is malaligned with the lower part. And as it is malaligned, what is happening? There is formation of a huge non-restrictive ventricular septal defect, and there is narrowing of the pulmonary artery. You know, the pulmonary artery, the infundibular part of the ventricular septum is continuous with the septum between the aorta and the pulmonary artery. So if it is shifted to the right, pulmonary stenosis also will be there, and also infundibular stenosis will be there, and aorta is overriding the right ventricle. So these four defects are produced due to a single defect, that is the shifting of the malalignment of the upper part, infundibular part of the ventricular septum. There is a first reported in a journal of 8 cases by Dr. Fallows in 1888. Dr. Fallows has reported this journal from German cardiology journal from German. And before that, from 1600, different people like Peacock, like Dr. Steno, they are searching for these very abnormal findings in post-mortem examination of this type of patients. But all these in living patients with these type of manifestations are first demonstrated by Fallows in 1888, and from that time it is known as tetralogy of Fallows. Sometimes if there is some addition of other people there, if there is ASD is present, it's called pentalogy of Fallows. These are not a very important thing, but the additional names are given there, and also not very valuable also. So what is important is that here the circulation is dependent. The cyanosis is the important manifestation. Manifestation of cyanosis is dependent on the degree of the pulmonary stenosis. This pulmonary stenosis may be at the level of the valve, that is the valvular pulmonary stenosis. It may be at the level of the lower part of the valve, infundibular pulmonary stenosis. It may be above the level of the valve, that is called supravalvular pulmonary stenosis. Sometimes the one branch of the pulmonary artery may be hypoplastic or may be absent. So there's various types of relation, various types of problems arising in the pulmonary artery. So we know that pulmonary circulation is very important for survival and very important for oxygenation of the baby. So if it is not properly oxygenated, there will be cyanosis. And you know also that cyanosis happens when there is reduced hemoglobin is more than 5 gram per dl in the arterial blood, in the capillary blood. Sorry, in the capillary blood, if you found the reduced hemoglobin is less, what is happened? Reduced hemoglobin is say more than 5 gram per cent. It is called cyanosis. If the reduced hemoglobin is less, say 3 grams, suppose a patient with severe anemia, hemoglobin percentage 3 gram percentage, patient may present with cyanosis. So cyanosis presentations, it depends on what is the amount of the hemoglobin present there. So saturation of the oxygen also depending on the amount of the hemoglobin is there. Usually if the say amount of hemoglobin is normal, we should think of that in about say less than 85% or 80% saturation SpO2 value gives rise to usually cyanosis, or more than 5 gram per del reduced hemoglobin in the blood can give rise to cyanosis. Now, what is maybe the amount? The most important thing is that the reduced hemoglobin or deoxyhemoglobin increased if the pulmonary suppression is not properly going. Now, what is happening in a baby after birth? A baby after birth may be asymptomatic in the case of tetrahydrocephalus in spite of all these defects. Now, why? Because you see just after birth, the pulmonary vascular resistance is high. And as the pulmonary vascular resistance is high, so you see pulmonary vascular resistance is high. Naturally, at birth, what is happening? The blood is solely coming from the pulmonary artery, and this pulmonary artery, if the stenosis is not critical enough, if it is not critical enough, then it will pass through this pathway to supply the pulmonary artery. So at birth, if the pulmonary stenosis is not critical enough, it will have to go through the pulmonary artery. Now, this causes the absence of cyanosis in tetrahydrocephalus just after birth, and it will gradually develop cyanosis from 4 months sometimes, or say sometimes it may delay for 6 months. Why? Because with gradual increasing of the age, this stenosis gradually increases. So degree of pulmonary stenosis increases with the increasing age. What is the reason behind this increasing age and degree of pulmonary stenosis is there? Because you see a newborn may not show cyanosis in desaturation, early desaturation of the blood, because a newborn contains huge amount of the, say, hemoglobin is there, larger amount of hemoglobin is there. So whatever it may be, it may not show cyanosis. Early it can survive with the low oxygen tension even, because it is habituated with that. With increasing age, the oxygen demand of the body, because of the increasing activity of the baby, oxygen demand is high. So number one is oxygen demand is high. Second important thing is that because of the more and more activity, there is more and more secretion of the catecholamines. More and more secretion of the catecholamines, more and more sympathetic drive is there. So what is happening? These two factors causes the more and more, say, thickening of the infundibular part, and also this infundibular part, if it is present in 50% cases of tetrahydrocephalus, and it will be thickened. And in stenosis also, that is gradually rising with the increasing age. So from 4 to 6 months of age, we'll get the cyanosis. Before that period, in the newborn, when the pulmonary vascular resistance falls, suppose the conditions, the pulmonary stenosis is not severe enough, it is allowing blood to pass through the pulmonary artery, and the pulmonary vascular resistance is high, and because of the high resistance in the newborn period, no blood is coming from the left ventricle to the right ventricle, but some blood is going from the right ventricle to the pulmonary artery, and it is maintaining the oxygen level of the newborn. Now, suppose when the pulmonary vascular resistance falls, the right ventricular pressure is also falling at the initial stage, and there is a pulmonary stenosis is not sufficient enough to prevent the entry of blood. What will happen? The blood from the left ventricle will go to the right ventricle and will pass through here, and the clinical picture will just like a case of ventricular septal defect. This is the peculiarity of this disease, is that it is very difficult to diagnose it from the first part of the life before the development of the cyanosis, unless and until you are very much aware of the condition, very much critical, very much suspectful. It is difficult to diagnose. It will present just like a case of BSD. I have known the very famous cardiologist to failing to diagnose the tetrahydrocephalus in the early part, and diagnosed as BSD, stamped the case as ventricular septal defect. Why? Clinically, But after investigation, it is changed, diagnosis is changed. Why? Because in the newborn period, if the stenosis is not, as the stenosis is not severe enough, so as the right ventricular pressure is not getting high, so blood will come from the left to right. With increasing age, what will happen? From 4 months or 3 months of age, the stenosis is higher. So right ventricular pressure is also increasing, and right and left ventricular pressure are more or less equal in case of tetralogy of Fallot, just like cases of endocardial cushion defects. Now next, where the blood will go? How the blood will go to the pulmonary circulation if both the pressures are same. So if both the pressures of the left and right ventricle are same, both will try to eject blood to the aorta or through the pulmonary artery. You see, the left ventricle is trying to eject the blood to the aorta, and right ventricle is trying to eject the blood to the pulmonary artery and the aorta. So aorta is getting blood from the two sources, left and right ventricle, and pulmonary artery is getting blood from the one source only, right ventricle. These pressures are equal. So on which factors the pulmonary circulation is dependent? On which factor the pulmonary circulation is dependent? It is the degree of the pulmonary stenosis. It is the degree of the pulmonary stenosis which indicate what is the amount of the blood will go into the pulmonary circulation. If the degree of stenosis is less, then more pulmonary circulation will be there, and the child may present without cyanosis, and that condition is known as pink Fallot. You are getting Fallot septology in the echocardiography, but you are not getting any cyanosis there, pink Fallot. Why? Because the degree of pulmonary stenosis is not sufficient enough to deoxygenate the blood to that level which produces the cyanosis. With increasing age, from 4 to 6 months, because of the pulmonary stenosis, naturally, I have just discussed, the blood will go to the aorta only in conditions when it is not possible to pass blood to the pulmonary artery, because this is the natural passage. Blood will try to go from right ventricle to the pulmonary artery through the natural passage, but if the natural passage is blocked, then it is forced to go to the right, so to the aorta. What is happening? This will cause the right to left shunting, and there will be cyanosis. And this will be aggravated particularly during exercise or during play, during crying, as like in the above case. During crying, during exercise, and during play, what is happening? Say there is more and more blood will go to the aorta. Why? Because the fall of the pulmonary, say aortic resistance, peripheral vascular resistance, or peripheral resistance fall during exercise. During exercise, the peripheral resistance falls. What is the need of the falling of the peripheral resistance? Because the muscle needs more and more blood, the relaxation of the small vessels are there. If the small vessels relax, naturally, there will fall of the peripheral vascular resistance, and more blood will pass to the aorta, and the baby will become more and more blue, and that is called cyanosis, cyanotic spell. It usually much more before the age of 1 year, and may more common also up to the age of 2 years, but usually after the age of say 1 year, child begins to adapt to some extent. Whenever there is difficulty in oxygenation, say whenever there is a difficulty during playing is present, child may adopt a position so that the peripheral resistance can be increased by knee chest position or squatting position. Because of the folding of the popliteal vessels, because of the folding of the femoral artery, the knee chest position is very important position for increasing the peripheral resistance, that is for preventing the blood to go down, and that increases the peripheral resistance, and so less and less circulation from right to left side. There is sometimes the baby, particularly before the age of 1 year, baby try to say mother will take the baby in the lap, and in the lap of the mother, naturally because of the kinking of the artery, peripheral resistance will increase. At the same time, sometimes some baby lie down on the ground, and this lying down causes the decreased sympathetic drive. I have previously told you that increasing sympathetic drive causes more and more spasm of this infundibular area, because the largest amount of the beta receptors, beta 1 receptors are present here. So they get stimulated, and if the child is lying down on the area, then there is naturally sympathetic stimulation is less. And sometimes the baby may stand with the crossing the legs, just like our Krishna Thakur. What is the purpose? Just kinking of the femoral artery so that peripheral resistance is increased. So these are the various ways the child may draft, and if it is not possible, child is developing cyanosis, they will run to the hospital for management, and naturally the doctors, what we usually do, we give the knee chest position, we give oxygen, we give IVD, because dehydration is also an important cause. We give some sedatives for proper relaxation of the baby. We give some, say, increasing peripheral resistance drug like say phenylephrine, etc. And we give say because of the say cyanosis, there is some say anaerobic metabolism is there, and there is acid production. pH is getting low, so acidosis is there. So sodium bicarbonate is given to prevent the acidosis, and sometimes propranolol is given as IV. Propranolol as a beta blocker, that may be helpful in some cases. So these are the various ways we do. If it fails in higher center, usually they do some operative measures like some shunting of the blood from subclavian artery to the pulmonary artery, just to save the life of the baby, and subsequently the surgery is needed. So these are the treatment. But sometimes we give the, say in these children, we should give the prophylactic management so that this type of spasm is delayed by giving the very high dose of propranolol to this side. Though there are theories are there whether the propranolol is effective, sympathetic blocking is effective, whether the sympathetic hormones or sympathetic overactivity stimulation of beta 1 receptors, they are much more effective here or not. These are controversial statements are there, because in case of pulmonary atresia, you will also get same times of cyanotic spell. So if pulmonary atresia is there, while there is a valve is say not there, atretic there, how it is a propranolol is active? This type of questions are there. These questions are not solved till yet, but till now this is the treatment of choice for prevention. One important thing we will have to remember, that we should increase the hemoglobin level in this case. Almost all cases of cyanotic heart disease should be started with the iron. This is our observation. At least hemoglobin level should be kept above 14 gram per dl. So in majority of our children, particularly those who are suffering from these diseases, they usually developmentally below the average, because they are getting the cyanous blood. Hypoxica is the manifestation. How will they develop normally like other child? It is not possible. So you will have to see, you will have to give iron, or you will have to give propranolol in these cases, and so that it can to some extent can get relief from this huge cyanotic spell, and take the early decision as soon as the child is gaining weight. The facilities are available. Now the facilities are available much more in comparison to previous. We are getting more and more surgical, post-surgical cases, post-operative cases of tetralogy of Fallot cases. So there are lots of other complications, like say sometimes hemiplegia may be a manifestations, sometimes infective endocarditis may be manifestations. Lots of manifestations may be there. We are not discussing this. So we will go to our next important cyanotic heart disease. This is the transfusion of the great arteries. Aorta is taking origin. Here you look at this figure. Aorta is taking origin from the right ventricle, and the pulmonary artery is taking origin from the left ventricle. The pulmonary artery blood is going to the lung. returning back to the left ventricle via the pulmonary vein, then again going to the left ventricle and again ejecting blood to the pulmonary artery. And aortic blood is taken from the right ventricle and going to the aorta systemic circulation, again returning back via the superior and inferior vena cava to the right atrium, then to the right ventricle. So the systems is getting more and more desaturated blood, and pulmonary artery is always getting desaturated blood. Is it possible to survive in this case? The answer is no. Unless and until there is some communication, between the two, this baby will not survive. And it is one of the important cause of abortion. And so in nature, we will try to survive the TGA patients by keeping some abnormality either in the atrial septal defect or in the ventricular septal defect, or keeping the ductal cyanosis. So just like here also, just after birth, if you see a baby is suffering from severe cyanosis, not due to a pulmonary origin, you may think of, you could keep the ductus open. You should start the PGE1 infusion, and if you find by echocardiography in your SNSU or the NICU, if you find the TGA is present, with the help of pediatric cardiologist, you should do the balloon atrial septostomy. Balloon atrial septostomy, just a communication between the right atrium and the left atrium. Right atrium and the left atrium, a communication should be maintained. This marking is not correct. The right atrium to the left atrium should be there. So communication should met, and so that there is some mixing of the blood from left to right. So if the communication is there, naturally the left ventricular blood will come to right ventricle, some mixing of blood will be there, and that some oxygen blood will go to aorta. Or sometimes the nature will try to keep some defect here, the ventricular septal defect, so the left ventricular blood will go to the right ventricle and supply to the aorta. Or sometimes nature will keep the PDA so that the pulmonary blood is go to the systems and survive the baby. So there are different types, 3 types of, say, TGA. First important type is very common. In 98% of cases, we'll get the ASD cases, and in rest of the cases, some BSD with TGA may be present, or PDA with TGA may be present. In case of, say, TGA with the VSD, in case of TGA with the PDA, or in case of TGA with a very large ASD, first term, second term, the cyanosis is less common. Rather the reverse. In case of TGA with the VSD or TGA with the large PDA, the child may present with the pulmonary congestion, and the child may present with the heart failure in the early life without cyanosis. And it may mimic the ventricular septal defect. But findings are also similar like the VSD or the PDA. But one important thing you should remember in this case, that there is every chance of development of the pulmonary hypertension here, and every chance of development of the pulmonary stenosis here. Now, this pulmonary stenosis, then there is a give rise to less amount of surface to the pulmonary artery, and there is more and more cyanosis, more and more jeopardize of the condition will happen. So here, to get rid of the situation, we should do the early operation of Ejection. Just keep this aorta here and keep the pulmonary artery here by doing the operation of Ejection within 2 weeks. And if you delay for more than 2 weeks, what will happen? There will be some anatomical changes in the right and left ventricle, and some changes in the pulmonary artery and the aorta. There may be difficulties there. The coronary artery circulation is maybe jeopardized in case of, say, in Ejection operation, so we should take special care of the coronary artery. cases. If the child is delayed, then other type of operation we should do and for survival of the patient. In that case, there shall be some connection may be made through the VSD from right ventricle to the pulmonary artery, from the left ventricle to the aorta. These are difficult operations under the domain of the cardiac surgeons. They should do if the child is delayed for that. Our purpose is to diagnose the TGA very early and very early referral so that arterial switch operation of Jatten may be done. And Jatten is a very well-known cardiologist. At the age of 28 years, he first described that this arterial switch operation of Jatten may be life-saving in TGA. We are just after TGA, there are lots of other diseases that I have not mentioned here. There may be diseases like single ventricle, but this is the prototype of the disease. Then sometimes the ventricle may be single ventricle. Usually clinically diagnosis is very difficult. It is echocardiography diagnosis. Sometimes there may be double outlet right ventricle. Both the aorta and the pulmonary artery is originating from the right ventricle. And it may happen double outlet right ventricle. Suppose the aorta is coming here much more than 50% of the say aortic orifice is coming to the right ventricle. It may be defined as double outlet right ventricle. So because the right ventricle blood is more past the aorta. So these are complex diseases. Sometimes there may be tricuspid atresia. In tricuspid atresia, what is happening? In tricuspid atresia, this tricuspid valve is atretic. What is happening there? As the tricuspid valve is atretic in tricuspid atresia, the right ventricle will be rudimentary in tricuspid atresia. What will happen? The right atrium will be dilated and that blood will pass via the atrial septal defect, which is must in tricuspid atresia. If it is not present, the child will die. From the atrial septal defect, the blood then will pass to the left atrium, then pass to the left ventricle, and then there is usually a VSD is present. Then via the VSD it is coming to the right ventricle and then ejected into the pulmonary circulation. If the VSD is not there, then survival depends only on the patency of the ductus arteriosus. So in case of tricuspid atresia, as the tricuspid valve is atretic, here there is no blood is coming from the atrium to the ventricle. So right ventricle is rudimentary usually unless VSD is present, and the right atrial blood is going to the left atrium, then to the left ventricle. Usually in majority of cases VSD is present, and depending is present, it will come here and supply the pulmonary artery. If it is not present, this pulmonary artery will get blood only from the ductus arteriosus. Here also, in case of tricuspid atresia, which ventricle is taking the load? It is the left ventricle. So this is the cyanotic heart disease. This tricuspid atresia. This is not. I am discussing this with the trilogy but back in tricuspid atresia, what is happening? Which ventricle is taking the load? It is the left ventricle. So a cyanotic heart disease baby presenting with a left ventricular hypertrophy, your first diagnosis should be, am I dealing with a case of tricuspid atresia or not? There are other say complex heart diseases like say total anomalous pulmonary venous return or partial anomalous pulmonary venous return. You know the pulmonary veins normally returns on the left atrium and all the 4 pulmonary veins is coming to the left atrium. Suppose the 2 pulmonary veins are draining in the right atrium, another 2 pulmonary veins draining on the left atrium. So right atrium is getting extra amount of blood from the extra pulmonary veins which are draining this, in addition to right and in addition to inferior vena cava and superior vena cava. So it will pictures. The picture is just like a case of atrial septal defect. It is not a problem, simple case. Now when the total 4 pulmonary veins, they are not draining in the left atrium. All the pulmonary veins are draining in the right atrium. Then what will happen? How the baby will survive? Again, the survival of the baby depends on the whether ASD is present or not. There must be a defect in the atrial septum to pass the blood from the right atrium to the left atrium, then going to the left ventricle. Otherwise, left ventricle will not get the blood because all the pulmonary veins are coming to the right atrium. So they will present in the early with the cyanosis unless and until the right atrial septal defect is sufficient enough so that the sufficient oxygenation is present. The important thing is that the system is getting less amount of blood. Pulmonary artery is getting more amount of blood. That blood is not coming back to the system in total and pulmonary venous system. It may be of different types depending on the types of the blood which is going on. The presentation may also get different. In TA-PVC, it may present with the cyanosis and other manifestations. It may be supracardiac drainage. Sometimes all the pulmonary veins may drain into a separate venous channel, and that veins drain into the right atrium. Or sometimes all the pulmonary veins, they drain into superior vena cava, and then they drain into the right atrium. Sometimes they get divided and drain. So it may be supracardiac variety, it may be cardiac variety, and sometimes all the veins, they are going down and then drains into the inferior vena cava. This is a dangerous variety. All the pulmonary veins that are going down and drains into the inferior vena cava. What will happen? There will be some obstruction of the venous drainage. So pulmonary veins, if they are from its normal site of drainage in the right atrium, it is going down, all the pulmonary is going down, and it is draining in the inferior vena cava. There are all chances of obstruction is there. And if there is obstruction, so pulmonary venous pressure will be increased. And if the pulmonary venous pressure is increased, there will be pulmonary capillary pressure will also increased. And if the pulmonary capillary pressure is increased, there will be pulmonary arterial hypertension will be there, and also leakage of the fluid in the lung. And the lung will be full of blood, just like a case of acute left ventricular failure. The baby will present with severe respiratory distress. And here, as all the veins are coming from there to the inferior vena cava, so you will get in X-ray a sign known as scimitar sign. Scimitar is a sword used by the African people. And in the X-ray, you will get a sign known as scimitar signs, but we do not bother with this name of these signs. But important thing is that you should diagnose the case as early as possible. It will present just like a case of hyaline membrane disease. Lung will be such white lung with a severe respiratory distress. So see how it is difficult if it is not known early that the inferior variety of the total venous connection may give rise to this type of presentation. So there may be lots of other mixing of the malformations may be there, and we will not discuss all. It is not possible for this just outline classes. Every classes, large number of classes are needed for this. I am just giving some hints of the very important disease that is called obstructive disease. Obstructive cardiac diseases are number of there, say coarctation of the aorta, like aortic stenosis, pulmonary stenosis. I think these are easy, you know. Pulmonary stenosis, the pulmonary artery is getting narrowed. Aortic stenosis, the aortic valve is getting narrowed, pulmonary valve getting narrowed. It may be below valve, above valve. Aortic valve may be below, maybe above, etc. But important thing is the coarctation of the aorta, because it can be diagnosed early. If you feel the pulse in the lower limbs and upper limbs, and if you find the very low volume of the pulse in the lower limbs in comparison to the upper limbs, if you measure the blood pressure in the upper limbs and the lower limbs, or in between upper limbs, and if you find that the upper limbs blood pressure is higher than lower limbs blood pressure, it indicates that there will be coarctation may be present there. Also, you will get the narrow volume of pulse in the arterial dorsal speed is usually not palpable. Popliteal artery is not palpable. So narrow volume of pulse is there. So this coarctation of the aorta usually occurs distal to just at the side, distal to the attachment of the ductus arteriosus. Here you see the important thing is there. Now in the ductus arteriosus, you see that ductus arteriosus, if it is present, there is no problem. The blood will go to the these three circulation, also lower limbs easily. Let us consider one situation where there is no abnormality present in the ventricular septal defect, no VHD is present or nothing, no abnormality is present here, and only ductus is present here. Ductus present here, coarctation is there in the intrauterine life. What is there? What will happen there? As the problem is not there, so after birth, what will happen? After birth, what will happen? Now, there is some narrowing here. Ductus is there, but some narrowing is there. Because of this narrowing, the lower part get less amount of blood in comparison to the upper part. So upper part will try to communicate with the lower part by formation of collaterals. By formation of collaterals. If these collaterals are formed, there is no problem. There is no problem, the newborn will survive properly. You diagnose the stress and do the necessary correction operation. After some times, the baby will survive. But suppose these collaterals are not formed. Collateral are not formed properly. That may happen in some newborns cases. Now, if the collaterals are not properly formed between the upper and lower part, in that cases, there will be usually the hypoplasticity of this aorta and other things. Hypoplastic of this. Now, why it is so? Because it is not needed to form. There is no need of increasing more and more force here to push the blood here. Now, if the hypoplasia of this artery is present, if the isthmus is more and more narrowed, the baby will present very less amount of blood supply to the periphery, and there will be severe respiratory distress. There may be cyanosis at birth. There will be less amount of circulation in the lungs. So all systems will be jeopardized. You will have to keep the ductus arteriosus open here in severe coarctation, and immediate surgical intervention are needed. Let us go to some consensus guidelines of this difference. And this is one guidelines published in 2007. After that, there is no guideline is there. Only the large number of people are there, and it is published in Indian Pediatrics also, accepted by all the cardiologists. There are some difference from the Western books. Considering the situation of India, they have recommended some changes in the timing of operation here. Now let us go to the atrial septal defect. Asymptomatic child, tie intervention after 4 years. Don't keep the child, say, for the long time. As it is ASD, keep the child after 4 years for the long time. Do not keep that, because ASD can give rise to some paroxysmal embolism. There will be some cause of, say, cardiac problem like the rhythm problems may be there. And then you go to the another area, there is a symptomatic ASD, means large ASD with sometimes a congestion. Sometimes the large ASD has every chance of every complications. So early closure is needed. And beyond ideal age, if the child is coming, say, 5 years, 6 years, or 7 years, try to do elective closure, depending on the time. Now, ASD gets more than 3 Less than 3 millimeter ASD usually closes in almost all cases, but that must be within 4 years. And say from 3 to say 4 to 8 millimeter cases, they usually closes up to 4 years maximum time, and after above 8 millimeter ASD, that usually does not close. And also remember the sinus venosus type of ASD, that should be taken into consideration at the age of 1 year. Go to the VSD, wind ear diameter, depending echocardiographer diameter manages the diameter of ASD by large VSD, by large VSD when the diameter is equal to the aortic orifice diameter, moderate when it is less than the aortic orifice diameter, small less than 1/3 of the aortic orifice. Now, echocardiographer, they will give the large, moderate, or small size dimension. They will mention that, and they also mention the location of the VSD, whether it is subpulmonic, whether it is outlet VSD or infundibular VSD or suprachiastic VSD. These are all same. It means VSD in the higher part, upper part of the ventricular septum and the infundibular regions. Perimembranous VSD is usually in the subaortic regions, just surrounding the membrane. This subaortic VSD is dangerous because though maximum cases of VSD, 80% cases are perimembranous, but problem is that sometimes there may be some sort of say aortic valve prolapse or aortic regurgitation may be there in perimembranous VSD. If the aortic regurgitation is there, the child may present with the severe problem, cardiac problem, heart failure will be there, and this should be operated urgently. So perimembranous VSD you should take care of, and if the VSD is small, that may close in 30 to 40% of cases or going flat. Inlet type of VSD usually in relation to the atrioventricular valve, usually it does not close properly, so it should be taken into consideration. Infundibular or outlet VSD, that also does not close properly. Muscular VSD closes, but except this multiple ship-like VSD, where there is multiple orifices there, that will not close properly. Now, these are the timing of closure as recommended by the consensus committee. The large VSD as soon as possible closure is required. Moderate VSD with pulmonary hypertension. Remember, pulmonary hypertension means the pulmonary blood pressure should be less than 50% of the systemic blood pressure. That is very important. And if the pulmonary hypertension moderate, it means the pulmonary hypertension is increasing, but it is not causing the 50% of the systemic blood pressure. Early operation, 3 to 6 months operation is essential. In the late, without pulmonary hypertension, you can delay. If it is 1.5:1, not 1:1, it is 1.5:1 shunt, that should be closed by 4 years. Small outlet VSD less than 3 millimeter, you can follow up to see the aortic valve prolapse, but that usually not closed. This should be operated. Aortic valve regurgitation, immediate surgery is needed. The prolapse of the aortic valve should be closed 3 years, by 3 years. Small VSD with infective endocarditis history, early closure is required. So these are some problems may be asked during exam of PG student. Now PDA, significant PDA means when the PDA is presenting with some sort of say cardiac or CCF, it needs early closure by 3 to 6 months. Without CCF, you will have to close by 6 months to 1 year. Small PDA, wait for 1.5 years and see what is happening. And in full-time baby, it should be closed because in full-time baby PDA, say usually closes and within 3 months of age. So after 3 months, you should take care of what is happening there. Silent PDA, only diagnosed by echo, no murmur is there. Clinically, nothing is there. So that should be nothing to do. That will close spontaneously. Silent PDA occurs only PDA diameter is less than 3 millimeter, usually closes. And PDA is a preterm baby with CCF. Early intervention is required by giving drugs like furosemide or SC inhibitor, surgical ligation is above the valves. Endocardial cushion repair, I have told you, immediate intervention. If the cardiac failure is present without CCF, 3 to 6 months just to gain weight and vaccination early. A partial ECD means ostium pivum, you can close 2 to 3 years. Coarctation of the aorta, CCF, immediate intervention. Without CCF but with hypertension, the should intervene just after the age 6 months, beyond 6 months. No problem within 2 years, and always see the Doppler gradient. If it is less than 20 mm Doppler gradient, no intervention is needed in coarctation. In aortic stenosis, normal left ventricular function, but echocardiographer will give you gradient if it is more than 50 mm gradient. So if the left ventricle is involved, dysfunction is there, immediate intervention, failure is there. If it is not, if the gradient is more, if STT changes, mean ischemia is there, or symptomatology, mean difficulty in respiration, it needs intervention early, operation. Balloon operation or balloon dilatation or valve replacement. Usually balloon dilatation is required nowadays. Pulmonary stenosis, similar thing, right ventricular dysfunction, immediate intervention, or normal right ventricle with Doppler gradient greater than 60 mm needs intervention. So echocardiographer will make guide, and if you remember this, they will guide the immediate refer the patient to the area. Tetralogy of Fallot medical therapy, I have told you before, beta blocker and the iron, and as soon as the child is gaining weight to some, I need early operation, early intervention. Other cases of cyanotic heart diseases, intervention is needed depending on the conditions. Complex cyanotic heart disease requires intervention as early as possible, depending on the weight and the hemoglobin percentage of the child. Tetralogy of Fallot should be operated after 6 months of age if everything is normal, and in some areas they operated just after neonatal period, depending on the possibility of the everything there. So here is the end of the just approach, and I request students to ask questions if they require. Now I am say stop sharing. Student can ask question. Acha. No question is coming in the chat box. Abhijit, hello. No question is coming in the chat box. In the chat box, there is no question.
Yeah, should we conclude then?
I'm already discussed them. Your proposal discussion is complete.
Thank you, Professor Datta, for your extensive speech on congenital heart defect, approach to congenital heart defect. I think those who have participated will enrich themselves. And thank you once again. And thank you, the participants. And for the participants, I must say that stay tuned, and we'll be having many more such programs, and we'll be enriched. So thanks to all. And with that, I conclude this session of PG class.